We're going to talk about potassium shifts, so how potassium will shift inside and out of the cell. And then we're going to talk about electrolyte changes with diuretic use. So first, potassium shifts. Remember that most of our total body potassium is within the cell. It's intracellular fluid. And then only 2% is outside in the interstitium and the bloodstream, which would be the extracellular fluid. And the reason why this happens is thanks to this bad boy. This is the sodium potassium ATPase pump. Kicks sodium out, pulls potassium in. Okay. The other thing that can cause potassium to go inside and out of the cell is this hydrogen and potassium exchanger. So hydrogen's the ones that it's going to drive the direction of these exchangers, because as you can see, they can go either way. But wherever hydrogen goes, if hydrogen wants to go in, okay, then potassium must come out, because the goal of potassium in this case is to balance the charge. So you don't want all that positive balance to build up. So if you put some positive charge inside, positive charge will come back out. And then same for the opposite. Okay. So now let's talk about causes of potassium to shift into the cell. And if you cause potassium to shift into the cell from the blood, then you're going to get hypokalemia. You're going to decrease potassium inside the blood. So the things can cause this. One is alkalosis. Why would alkalosis cause this? And the key here again is this. Remember, if you have alkalosis here, where's the H plus going to go? Alkalosis means there's not enough H plus, so H plus is going to go in here. Actually, what's going to happen is H plus from inside the cell is going to go out, so that it can go into the bloodstream. So thus, remember we said potassium has to balance the charge. Potassium will go in to balance the charge. Now you get hypokalemia. Next is beta agonist and insulin. Both of them activate this sodium potassium ATPase. So you can see here there's a nice plus sign, and so they make potassium go in. So you can remember that because the insulin makes potassium go in. Finally, hypoosmolarity can cause potassium shifts into the cell. I just want to confuse you a little bit. The way I was confused by this at first, because I thought before, if this was hypoosmolar in the blood, if there was decreased concentration of solutes, wouldn't you want solutes to go into the blood from the cell and thus cause it to go out, which would be the opposite of what it actually is? And the reason why that's not true and that's not the case is because you always have to think about how water will move in cases of hypoosmolarity. Don't think about the solute, think about water. If there is low concentration in the bloodstream, remember water goes from low to high osmolarity. Water will go this way to high osmolarity. And what's going to happen is potassium concentration inside the cell because of this. Potassium concentration inside the cell is being diluted by this water, so you're going to get decreased potassium concentration. So to fix that, to get that normal potassium concentration, you're going to get potassium going into the cell again. Okay? So that's how all of these can cause potassium to shift into the cell, and that's going to cause low potassium in the blood, aka hypokalemia. Now the opposite, causing potassium shift out of the cell, opposite of the above factors all do it. So for example, acidosis, beta blockers, diabetes mellitus type 1, which is insulin resistance, hyperosmolarity, all of these cause potassium to shift out of the cell, and you get a hyperkalemia. The other things that can cause this, lysis of the cells. Again, if you lyse the cells, you basically break it open, and all that potassium can come out. So lysis of the cells can occur in things like crush injury, tumor lysis syndrome, and rhabdomyolysis. Okay. Next is digitalis. Digitalis works in the opposite direction of beta agonist and insulin. It blocks that sodium potassium ATPase, so you get less K into the cell basically. Finally, succinylcholine. Succinylcholine digitalis lyses the cells, and the opposite of the above factors all cause hyperkalemia. Next, we're going to talk about electrolyte changes with diuretics. And we're going to just go through pretty much every diuretic and examine their mechanism of action and see how they affect different electrolyte changes in the urine. So note, we're talking about electrolyte changes in the urine. You don't have to memorize this, I just want you to understand it. You'll be able to understand. If it's more in the urine, it's going to be less in the blood. Same as all, it's just like that. So what's that? How will urine sodium chloride change with diuretic use? Let's think about this loop of Henle one. Loop diuretics. Loop diuretics work at the loop of Henle, block this, and then so there's less sodium reabsorption, so you have more sodium in the urine. Okay? Same here for carbonic anhydrase inhibitors. Remember those? Block this whole reaction, So there's less sodium reabsorption, less bicarb reabsorption, so you have more sodium in the urine. So all of them increase urine and sodium chloride because they block sodium reabsorption. Next is urine potassium. How does urine potassium change? Well, let's look at loop diuretics and diazides first. Either of those, loop diuretics block here, diazides block at the distal convoluted tubule. There's less sodium reabsorption at these areas, so now there's going to be more sodium ending up at the distal convoluted tubule, okay? Because we just blocked absorption previously. If you increase all that sodium, guess what's going to happen? More sodium is going to go in here, and guess what? What goes in exchange for sodium? Sodium goes in, what goes out? Remember that potassium goes out. Remember we exchange it for potassium, so a lot of sodium go in, so a lot of potassium must be going out. So in this case, urine potassium goes up with these two diuretics. Now, the one that has decreased urine potassium is the one that is the potassium sparing diuretics. And how does that work? Where does potassium sparing diuretics work? When they can work either directly on this sodium channel, or they can work on the aldosterone that's activating this sodium channel. So they block this from happening. If you block this from happening, again, what happens? That means you have less exchange, so less of the potassium leaves, and so you have less urine potassium. Now I'm saying there's less urine potassium, so that's going to basically lead to hyperkalemia, or at least a normal kalemia. It's going to lead to hypokalemia. And this is why this one is called a potassium sparing diuretic. Okay, urine calcium. How does that change? Let's talk about loop diuretics first. How will urine calcium change when we block this? Well, think about how calcium gets reabsorbed. Remember, calcium is reabsorbed based on this positive potential that's generated, and it's generated by this potassium back leak. So if you block this, if you give them a loop diuretic, you're going to get decreased potassium in the cell. If you decrease potassium inside the cell, you're going to decrease this back leak. You decrease the back leak, decrease this positive gradient, decrease that potassium pericellular reabsorption. Thus, there's less reabsorption, there's more urine calcium, okay? For thiazides, what's going to happen? Thiazides, we're going to block. We block the distal convoluted tubule, right? And the calcium here is exchanged on this apical side. So what's going to happen? There's less sodium inside the cell because we blocked this reabsorption. So what's going to happen on the apical side is there's going to be a bigger gradient for sodium to go down. So the sodium is going to go down more, and then it's going to be in exchange for the calcium. So you get more calcium reabsorption, decrease urine calcium. Okay, and so now you can get hypercalcemia because there's more reabsorption, and this one can be hypocalcemia. Okay, next is blood pH. Let's talk about the causes of low blood pH. So let's say you have a carbonic anhydrase inhibitor. Actually, let's talk about blood pH. What's going to change it? It's going to change based on reabsorption / excretion of bicarb and H+. So either of those two changes can cause changes in blood pH. So how does carbonic anhydrase inhibitors work? Remember, they block here as well as here. So they're going to decrease reabsorption of bicarb. And so what's going to happen to your blood pH if you decrease the reabsorption of your bicarb? Your pH is going to be decreased. It's going to be more acid, okay? The other one is the potassium sparing diuretics. Let's clear everything again. Potassium sparing diuretics, again, the collecting ducts blocking this. So what's going to happen? Remember, the key thing is what gets exchanged for the sodium. And remember that sometimes we get H+ exchange, but if you're going to block sodium reabsorption, there's less H+ exchange. There's more H+ in the blood, and thus you have an acidemia. So that's how carbonic anhydrase inhibitors and potassium sparing diuretics lower your blood pH. Now, loop diuretics and thiazides actually increase your blood pH, and there's going to be 3 mechanisms for this. Number 1 is related to diuresis. Their diuresis is going to cause low blood pressure. What's going to happen? What's the renal mechanism in response to low blood pressure? And we're going to activate that renin-angiotensin system. And so you're going to get more aldosterone, you're going to activate it here, okay? Increased sodium reabsorption, again, so that means you get kicking out more of this H+, so you have decreased H+ here, that's one cause of the alkalosis. Now the other 2 causes are related to potassium loss, okay? Remember that both of these cause potassium loss in the blood. Loop diuretics and diazides that increase your potassium in the urine. Now, what is going to happen? Well, remember I talked about inside the cells. We have the potassium H plus exchanger. So if you're going to decrease potassium in the blood, that means potassium inside the cell is going to come out. It's going to go down its concentration and come out. And so in exchange, H plus is going to go into the cell. H plus goes into the cell, there's decreased H plus in the blood, so again you have an increased blood pH. Now finally, the last thing that happens, if you have low potassium in the blood, remember how sometimes in this collecting ducts, for the sodium reabsorption, we can either exchange potassium or H plus. If you decrease your potassium, then there's going to be a preferential excretion of H plus, so even more H plus is going out. So again, that's another way that you can get increased blood pH. So I forgot to tell you actually that these three mechanisms are a little lower yield, okay? So you don't have to memorize these. They are a little helpful just to understand, and they're kind of easy just because they're all based on the sodium potassium H plus exchange in the collecting ducts. But the important thing to know is that loop diuretics and diazides increase your blood pH. Carbonic anhydrase inhibitors, potassium sparing diuretics decrease your blood pH. And you don't have to memorize any of these, just really understand the mechanism of action of each of these diuretics. And then you'll be able to intuit all of it just based on, if you can understand what happens, then you understand your nephron physiology, you'll be able to understand how the electrolytes will change, and you'll be able to choose the right answer on step 1. Alright, so that's it.